التحيات والشكر والدعاء من مكة المكرمة ولحضراتكم طبعا. Tonight we will go through the critical care MCQ series as interactive sessions. احنا قدمنا منها جزء الاسبوع الماضي لو حضراتكم كنتوا ذاكرين، اللي هو كان الانفيزيف كانديدا انفكشن. طبعا انا هعرف بنفسي ان شورت. انا اسمي دكتور عادل حسين، انا كونسلتنت كريتيكال كير ميديسن حاليا في كينج عبد الله ميديكال سيتي في مكة المكرمة. I just have to highlight a difference between who is the God physician and the great physician. The God physician who treats the disease, while the great physician treats the patient who has the disease. And who is the God doctor? The God doctor who cares about the good learning to save lives. And I think tonight and further meetings in the Journal Club, this is one of their cornerstones or aims, is to have a good learning, then you can save life. And I think the project of our Professor Dr. Shif Mukhtar is the Southern Cardiac Death Prevention is to save lives. What had been presented by Dr. Mina is for the guidelines for VTs and the Southern Cardiac Prevention is to save lives. And tonight also we can present, I assume that we are presenting some informations that when you go back home to your patients in the ICU, it may save lives, as I assume this. So before we start our interactive sessions, المرة الماضية طبعا أضعنا وقت كثير إن إحنا نسمع من حضراتكم. بعض الناس أو بعض الزملاء بيبقوا محرجين إنه you go to unmute himself we start interaction، رغم إنه كلنا معرضين للإكزامز والMCQs والأوسكي، وهي ما هي إلا interactive session عشان to cut the bridge or to cut the obstacles في محاولة ان احنا نسهل الامر اثناء الاوسكي او حتى في امتحانات MCQs. واي امتحان الان في البورد في الفellowship لا يخلو ماستر MD لا يخلو من MCQ او اوسكي. فانه it's an interactive session. النهارده هنقدم شيء مختلف او هنقدم الاسئله بطريقه مختلفه، طالما معظم الزملاء بيبقوا محرجين انه to interact with us او they don't want to interact. عنده الكونسبت انه لو اخطا فبيبقى محرج، واعتقد انه ده كونسبت يعني الى حد بعيد مش صحيح. الغرض ان احنا مش بنمتحن احد، احنا just we are interacting to present some knowledge ممكن تبقى عندك وممكن ما تبقاش عندك، فده الغرض من الانتراكشن وليس الامتحان ولا مساله يعني استعراض العضلات زي ما بيقولوا. anyway it's an interactive session. الآن دكتورة نجلاء جزاها الله خير عملت very good job إنها حولت الأسئلة اللي هنعرضها إلى بول. إيه هو البول؟ زي التصويت. هنعرض السؤال وهنختار، مش هنختار بقى فولنتيرز. حضراتكم بعد ما يتعرض السؤال I will give 3 to 5 minutes maximum 5 minutes. طبعا 5 minutes هتكون طويلة شوية، لكن عادة هتكون at least 2 to 3 minutes maximum to read and answer. Then دكتورة نجلة هتعرض البول بالاختيارات ABC مثلا D E، وبعدين حضراتكم هتختاروا زي التصويت في القاعات، ودكتورة نجلة بعد كده هتعرض لنا من البول the percentage of each answer, 30% for A, 80% for, and so on. Then after we end the ball, so there is a time for the question or time for the ball. Then after each question, I will present the most correct answer. Then I will follow this with the rationale why we consider this as the most correctable answer. Then we highlight some teaching points. Then when you go back home, so you have some teaching points or some practical points, it will help you to go back and study the whole topic. And also I can provide, I will provide you some references about the topic. So here it will be like زي ما نسميها وجبة دسمة فيها السؤال والانسر والراشونال والتيتشنج بوينتس والريفرنسز إذا حبيت. وبنختم عادة كل سيشن بهوم وورك انه الان اعطينا 3 4 or 5 questions، كل question covering a topic. نرجع بقى نذاكر التوبيك ده كويس عشان اللي بي for clinical practice better or نقدر نقول standard of care practice، وطبعا finally عشان موضوع الامتحان. دي كانت مقدمة معلش طويلة شوية. So now we will go for the question number 1. Question number 1, a 60-year-old patient with a history of type 2 diabetes, hypertension, stage 3 chronic kidney disease with GFR of 35 millimeter per minute per his square area, admitted to the ICU with hypertensive emergency. There is a concern for a renal artery stenosis, and the magnetic resonance angiography or MRA with gadolinium is planned for further evaluation. And do not ask me why not you raise the concern for or image for something with without gadolinium like ultrasound, Doppler. Now this is the question, because there is an idea behind the question, and this is why the MCQ is there. So there is a concern for renal artery stenosis, in this case of hypertensive emergency, and there was a plan for MRA with gadolinium planned for further evaluation to rule in or to rule out the renal artery stenosis. The question is, would you proceed with MRA? This is the question. The answers for five answers. Yes, because the accepted GFR or glomerular filtration rate for gadolinium contrast is greater than 20 millimeter per minute per body surface area. B, yes, accepted GFR for gadolinium contrast is greater than 30 ml per minute. C, MRA with gadolinium is contraindicated in this patient. D, you have to start IV fluids first with N-acetylcysteine or Mecomest prior to administration to give the gadolinium contrast. E, yes, with plan for dialysis following the gadolinium administration. So now Dr. Najla, she will present the ball. So the poll here is the answers A, B, C, D, E. So you have to choose now based on the ball. Now you have 1 minute to choose. Then the ball will end. Then Dr. Najla, she will present your replies. So you have 1 minute to answer, guys. اعتقد البول تكون واضحه يا شباب. معلش هو السؤال طويل شويه يمكن، بس او الاختيارات طويله ككتابه، لكن I hope ان شاء الله تعالى تكون البول واضحه.
واضحه يا دكتور عادل ان شاء الله، ويكفي دقيقه للاختيار.
تمام. دكتوره نجلة, can we proceed for the replies? So according to your answer, guys, now question number, answer number A is 2%. The majority, 43%, they said yes, the accepted GFR for gadolinium contrast is greater than 30. 24% they choose C. 20% they choose to start IV fluids with N-acetylcysteine, and 11% of you they plan for E, or so they choose E, and they plan for dialysis with gadolinium. So this is your answer. So the majority of you chose B, and they said no, yes, it's accepted GFR for the gadolinium contrast in MRI study. It should be greater than 30. While still there is some variable answers. So what's the correct answer? So the correct answer with your majority, you are right. So the correct answer is B. Yes, when you plan for gadolinium study with the MRI, gadolinium is the type of the study or the contrast study used in the MRI, either MRI brain, MRI angiography, MRI abdomen. It's called a gadolinium-based contrast, different from the CT. The CT usually, or coronary angio, we use the ionic contrast in these studies. So, الآن what's the rationale for this B? Especially some of our colleagues choose dialysis, some choose IV fluids and N-acetylcysteine, and some choose 20 GFR 20 because of the risk what's so-called nephrogenic systemic fibrosis, NSF. This is a disease entity related to the gadolinium contrast when you have renal impairment or CKD or patient with EKI or patient on dialysis. So because of the risk of so-called nephrogenic systemic fibrosis, there is a recommendation to avoid the gadolinium in patient with those three patients: GFR less than 30, endothelial disease receiving dialysis, and patients who have EKI. So remember this very well. When you ask for MRI with contrast using gadolinium, look carefully for the GFR. If less than 30, it's contraindicated. Patient who have endothelial disease on dialysis, it's contraindicated. Patient with acute kidney injury, it's contraindicated. And why? Because of this nephrogenic systemic fibrosis. And this is one of the OSCE cases, by the way. So it's something you have to be aware and you have to know about it. A single hemodialysis session, by the way, it removes about 70% of gadolinium. Two hemodialysis session, it removes about or clear about 95%. And the three treatments with hemodialysis, it removes about 98%. But it's not the issue of the dialysis, it's the issue of the disease itself, and it's fatal, the nephrogenic systemic. So the proper prevention is the best, not the dialysis only. So if the patient have a GFR less than 30 and the gadolinium is mandatory or necessary, so the study or the images can be completed, provided that the patient will go hemodialysis. And this is the indication. If patient had one of those three, GFR or endothelial disease dialysis or EKI, and it's mandatory to have MRI or MRA, so here you will proceed, you explain to the patient, and to explain to them what's the incidence of nephrogenic systemic fibrosis, what's the nephrogenic systemic fibrosis, and the need for dialysis, maybe 1, 2, or 3 sessions. There are varying guidelines recommending the prompt initiation of hemodialysis not later than 2 hours after administration of gadolinium. So if you plan for dialysis, do not delay, please, for more than 2 hours, either intermittent hemodialysis or CRRT. And additional session of intermittent hemodialysis will be completed within 24 hours of the first session, and the third session will possibly recommended for at least 9 hours of the hemodialysis. So between second up to third or 3 sessions of hemodialysis, so you can clear up to 98%, but not 100%. Still the incidence is there. So خلينا الآن نشرح شويه in short ايه هو nephrogenic systemic fibrosis and why it's fatal. So nephrogenic systemic fibrosis is a progressive multi-organ fibrosing condition. It's a multi-organ. So remember, it's a multi-organ fibrosing condition. It happens after exposure of the patient to gadolinium-based contrast agent. The incidence is between 0.4 up to 8%. So it's not very rare. The most debilitating sequelae of the nephrogenic systemic fibrosis is the fibrosis of the visceral organs, heart, lungs, renal tubules, and skeletal muscles. And sometimes it's fatal if it is missed and not prevented or not diagnosed. With this visceral fibrosis, it's sometimes still asymptomatic with mild, but it may progress and contribute to severe pulmonary hypertension, cardiomyopathy, restrictive type, and skeletal muscle weakness. How you diagnose? Usually with skin biopsy. It demonstrates a dermal fibrosis without signs of inflammation. And this is the picture, the gross picture, how it happens here, if you can look carefully for the legs. So patchy areas of the fibrosis affecting the skin, other multi-organ fibrosis, as we mentioned earlier. And here under light microscopy, you have a dermal fibrosis, but interestingly, without signs of inflammation. There is an increased celerity, if you can see it under the microscopy, with a bundle spindle here, the bundle spindle shaped fibrotic cells with much myosin deposition. This is how we diagnose. So the only diagnosis is to have a low risk of suspicion, high risk of suspicion, plus identifying the risk factors and skin biopsy. As we mentioned, you have to avoid in those three patient categories. To date, as we mentioned, there is no proven treatment to cure this NSF. Restoration of renal function, if possible, is essential to prevent further progression or to hold the progression to be multi-organ. As we mentioned, it can affect the lungs, heart, pulmonary hypertension, restrictive cardiomyopathy, and severe muscle weakness. Some studies, they show limited skin lesion improvement by using intravenous immunoglobulin, but this is not evidence-based. Photopheresis and local administration of interferon. This is like a case studies of a patient who developed a nephrogenic systemic fibrosis and they did the dialysis and they have skin lesions. How can they improve the skin lesion? They give some IVIG, photopheresis, and local administration of interferon. There is some expensive intervention called extracorporeal photopheresis or ECP. It's not available in each center. This is provide the best tool to treat the skin lesions, but it's extremely expensive. And there is also called compression treatment for lipodermatosclerosis, which also help for the venous insufficiency. So these are some references for the nephrogenic systemic fibrosis. If you want to go back and read it, it's updated from 2006 till 2020. So it's very interesting, and you have to be aware because every day we are exposed to patients who need MRI or MRA or MRV, and they have some kidney injury or they are already on dialysis. Thank you. Jazakumullah khair. Thanks. I will move for the second question. So this is question number 2.
معلش دكتور عادل، ممكن كان ليا كومنت بس صغير.
اتفضلي.
دكتور عادل، حضرتك سامعني كده؟
طبعا.
اتفضلي يا نجلاء. اتفضلي.
تمام. ايوه تمام. انا بس كان ليا كومنت ان هو الجادولينيوم دلوقتي في انواع بقى، في انواع منه ممكن تكون يعني في جروبس منه في مور سيفر، يعني يقسموهم كده جروب 1 و 2 و 3، والمفروض جروب 2 دي هم السيفست و very low risk of nephrotoxicity، فبيبقوا recommended عاده في الحالات في البيشنتس سبيسيفيكلي. طبعا الجي اف ار بتاعهم اقل من 30، يعني طبعا ممكن يكونوا مش available في مصر. معرفش عندكم يا دكتور عادل بقى في السعوديه هل الديفرنت فورمز بتاعت الجادولينيوم دول موجودين ولا لا. ده غير ان في برضو كان consensus statement كده برضو اعتقد في 2020 كانت على الامريكان كولج اوف كارديولوجي والناشونال كيدني فاونديشن. مش عارفه اذا كانت موجوده في الريفرنسز اللي حضرتك عرضتها ولا لا. انا دي اعتقد اخر واحده كانت 2020، كانت مجمعه وجايبه سيره كل بقى collecting كل ال recommendations بتاعت الجايد لاينز.
ثانك يو دكتوره، ربنا يخليكي دكتوره نجله. زي ما حضرتك قلتي انا السلايد فعلا سوري الجادولينيوم از يو منشن طبعا زي الكونتراست او الايونيك كونتراست داي فيه منها many types to minimize the nephrotoxicity. But usually when we have one of those patients, especially with GFR less than 30, or patient who have end-stage disease on dialysis, or patient with AKI, and it's mandatory to have the gadolinium study. Usually what we do, it's multidisciplinary. We have to sit with the radiologist and to explain to them how this is important, especially if requested by neurology or neurointervention, for example. Then he is the one who can offer us. He said, yes, I have type 2 gadolinium, it's out of stock. So it depends. So as you mentioned, it's not available in each hospital, but I just emphasize this because it's a risk and it's sometimes fatal. Sometimes it's reversible if addressed early. So it's not our job as intensivists just to order, but address the risk, contact the radiologist, lock with him what is the most available and safest to minimize the risk of this nephrogenic systemic fibrosis. At the end, its risk is still not so rare. It's up to 8% can happen, especially in those three categories.
Let us start the next case.
So question number 2 is a 58-year-old female patient with non-insulin dependent diabetes, presents with lower leg swelling with severe pain. She fell while gardening yesterday and she had laceration on her heel. On examination, her blood pressure was 80s over 50s, heart rate tachycardic 138, she's febrile 39.4, her saturation 98% on 3-liter nasal cannula, and she's mildly confused. She had erythema, edema, and crepitus up to the mid-calf. Notably, laboratory workup, white count was 22,000, lactate 3.9. She has been admitted to ICU because she developed septic shock requiring norepinephrine after proper fluid resuscitation. Blood cultures were sent from the ER and started IV biptazo, which is piperacillin tazobactam, plus vancomycin. The question is, which is the most appropriate, sorry, which is the most appropriate next step in the patient management? A, to perform surgical debridement. B, to refer patient to HOP or hyperbaric oxygen therapy. C, to start IV immunoglobulin. D, to start IV clindamycin. Then you proceed for CT scan soft tissue protocol. So now we need your answers. And Dr. Najla, after 1 minute, she will present. She can present now the ball, and later on your answers. So A, B, C, D. Dr. Najla, can we proceed for the results? So majority, they answered A, 77%, which is they want urgent or immediate surgical debridement. 4% of the answer, they want to refer patient to hyperbaric oxygen therapy. And 2% they want to start IVIG. And 17%, which is not is a considerable, نقدر نقول 15 to 17%, they want to add clindamycin to the combination of vancomycin and biptazo, plus they want CT scan. So now the majority choose A. Okay, شكرا دكتور نجلة. So now the correct answer, yes, A is the most correct answer to perform surgical debridement. And why? The rationale is this patient has, if you go back to the scenario, this patient had, she was gardening and she had laceration, she is diabetic, and now she got erythema, edema, and crepitus in the mid-calf. So with a full-blown picture of septic shock, now they give you choices is to go for surgical debridement immediately as a source control or hyperbaric oxygen. And I don't know, is it for our colleagues who chose the HOP or hyperbaric oxygen therapy? Is it, I know it's available in Ma'had Nasser. I don't know other hospitals في مصر available فيها الهايبرباريك oxygen ولا لا. بس I think انت لو في القصر العيني او في عين شمس مثلا او في الازهر whoever of MH hospital, I think you may be limited to send your patient immediately with this picture to or this scenario to hyperbaric oxygen. Immunoglobulin, some of our colleagues that choose immunoglobulin, and some they want to start Clinda plus CT scan. So this patient as a diagnosis has what's called necrotizing fasciitis with this clinical picture we presented. And the necrotizing fasciitis is a life-threatening, aggressive skin and soft tissue. So remember, it's a life-threatening, aggressive skin, soft tissue infection, not only skin, that cause necrosis of the muscle fascia and subcutaneous tissue. For patient with necrotizing fasciitis, immediate unprompted surgical exploration is essential once you diagnose to determine the extent of infection, number one. Number two, to assess the need for debridement. Number three is to obtain a specimen for gram staining and culture. So it's a turn of you as intensivist or ER physician once you label this is a high index of suspicion for neck fasc to call the GS or the general surgery immediately. So before proceeding for any images, now you have clinical scenario, you have clinical suspicion, then you have to have a link with the GS or the surgeons for prompt surgical exploration for those aims, is to determine the extent, to assess the need for debridement, and to obtain a specimen for stain and gram and cultures. There is no single laboratory, a clinical laboratory test or group of tests that adequately replace the surgical inspection for the diagnosis of this infection. So remember this statement very well. There is no single clinical test or group of tests that adequately replace the surgical inspection. هو هيقدر يقول لك how deep is this neck fasc, how superficial, what's the optimal surgical intervention or debridement. In addition to the prompt surgical intervention, طبعا, of course, go without saying that appropriate early broad spectrum antibiotic that cover anaerobes and MRC or even gram negative, plus طبعا fluids, pressors, EBCs are essential to reduce the morbidity and mortality in case of neck fasc. What about the role of hyperbaric oxygen for people who choose the HPO is an adjunctive treatment. Remember this, it's an adjunctive treatment, has been debated, and there was no prospective RCTs has been published yet. The benefit of hyperbaric oxygen therapy for the treatment of neck fasc remain controversial. The surgical debridement should not be delayed in order to pursue the hyperbaric oxygen therapy. As we mentioned, patient is in septic shock, or even without septic shock, he needs surgical debridement, which is the best treatment option, plus broad spectrum antibiotics, as we mentioned, before you call or you waste your time for looking centers who have hyperbaric oxygen. What about the rationale for IVIG in patients with neck fasc is based on the rationale behind it is the ability to neutralize the extracellular toxins. So some people they like the IVIG and they are in a hurry to order it. And this is the rationale, is to neutralize the extracellular toxins that mediates the pathogenesis. But all the evidence, the clinical studies supporting its efficacy has been at serious limitations, and consequently the consensus supporting its use has been not reached yet. So again, nothing replacing the surgical debridement. What about the effort to inhibit the bacterial superantigens involved in the pathogenesis of Nick Fash are ongoing. This is a new modality of therapy, which is the agents that inhibit the bacterial superantigen. Still expensive, but still under clinical trials, does not reach clinical success to be generalized in practice. So the best answer in our case is A, is to perform surgical debridement. Just to move on, we have three types of Nick Fash. We have type 1, which is polymicrobial, and this is common in immune-compromised patient diabetes, like our scenario, or peripheral vascular disease. We have type 2 monomicrobial. This is typical group A streptococcus and Staph aureus. So you have to cover with antibiotics that specific for MRCA or group A streptococcus. Common in healthy individuals with a skin injury as part of infection. So monomicrobial mainly in healthy individuals, polymicrobial in immune-compromised or diabetic or peripheral vascular disease. Type 3, which is a gas gangrene caused usually by the anaerobes with the clostridial infection. This is the three types. How we diagnose the Nick Fash, the clinical signs of necrotizing soft tissue infection and Nick Fash include very important red flag, which is pain out of proportion. Remember this, pain out of proportion, edema extending beyond the erythema, plus fever. So do not rely only on the crepitus. The crepitus is only in 14%. So you may mess up to 85% without crepitus. So because the concept when we go to the ER assessing the patient, then the resident or fellow is telling, no, there is no crepitus. No. The crepitus is only in Nick Fash in only for almost 14 to 15%. So what about the remaining 80%? So erythema is 100%, polyinflammation in about 50%, skin necrosis if severe 14%. But before this, you have to have a clinical suspicion when you have pain out of proportion, edema extending beyond the erythema plus fever. And the red flag is pain which is out of proportion to the physical finding. Remember this very well. It's a red flag. And rapidly progressive soft tissue infection should be always suspected as necrotizing fasciitis, so you will not miss. So for the diagnosis of Nick Fash is primarily clinical one. Plain X-ray has no value for the diagnosis and has no role to differentiate Nick Fash from cellulitis. Remember this very well. CT scan can have greater sensitivity than plain film in identifying soft tissue infection and necrotizing fash, and to give you the extent of the Nick Fash, but do not delay if you have a clinical diagnosis. Under local anesthesia, there is some surgeon, they can do probing with the finger for signs of a Nick Fash. The necrotic tissue, as we mentioned, can be penetrated with a little resistance, aspiration, or gram stain. Also can be done on examination. Some people who are expert in the POCUS or point of care ultrasound, they can use the P-mode, color Doppler ultrasound that can help now in the early diagnosis of Nick Fash at bedside. If for people who are expert in soft tissue ultrasound, not our usual POCUS. So remember, there is no lab or image test should delay the surgical intervention. There is some scoring system. This is one of the scoring system. We call it laboratory risk indicator score for Nick Fash or LARINIC. This LARINIC is, we have C-reactive protein, total white count, hemoglobin, sodium, creatinine, and glucose. And this is the score. If the score equal or more than 6 as cut-off value, with positive predictive value of 92% and negative predictive value of 96%. So if you have a score less than 5, so there is a low risk, less than 50% of Nick fasciitis. If the score between 6 to 7, a moderate risk. If the score more or equal to 8, it's a high risk, more than 70%. But remember, 90% of patients with Nick Fash had the score of more or equal to 6, while still about 8%, 3 to 8% of the control patient, they have a score equal or more than 6 also. So still not 100% sensitive, not 100% specific, but you can use it as a scoring system, especially it requires the labs when you ask it on initial evaluation. But again, if there is a high suspicion or clinical high suspicion of neck FASH through clinical history, physical exam, do not calculate the scoring, whatever its sensitivity, and go straight for surgical debridement. Broad-spectrum antibiotic and serial labs to monitor the response for your treatment. If the score is less than 6, it's a low risk, but not no risk for necrotizing fasciitis. Remember this, and you cannot exclude 100%. Overall hospital mortality of neck FASH between 17 to 40%. Surgical debridement should be done early, within 6 to 12 hours, do not delay. It should be complete. What does it mean complete? Removal of all necrotic tissue as possible. If the patient is not in the IC or not bleeding or for operative circumstances can allow, it should be complete from the start. Delayed surgical debridement beyond 12 hours time window is associated with a higher mortality, higher incidence of septic shock and multi-organ failure, and requiring of more surgical debridements than patient who had early surgical debridement. So early surgical debridement minimize further surgical debridements. What does the evidence base tell us regarding this patient? Regarding the neck FASH. This is the latest guideline in 2018, recommendation for the management of skin and soft tissue infection. So they are emphasizing the surgical rule as source control as soon as possible within the first 12 hours, do not delay it. And the early source control, antimicrobial therapy or broad spectrum early and appropriate plus supportive measures are cornerstone for managing patients with neck FASH and sepsis. This is regarding the source control derived from the latest surviving sepsis campaign guideline published last year. And the emphasized patient with sepsis and septic shock, they recommend rapidly identifying or excluding a specific anatomical diagnosis of infection that require emergent source control and implementing any required source control. So early source control is mandatory, not only antibiotics, not only fluids, not only pressors. So source control and sepsis and septic shock is mandatory. And this is evidence-based with the latest guidelines. And now for patients with sepsis or septic shock, also they recommend to remove any intravascular devices that possible to be a source of sepsis or septic shock. And this is what we call the 4 Ds of source control, the core of 4 Ds of source control. So when you face patient with sepsis or septic shock, ask yourself, I agree with you, you have to give early antibiotics, you have to give fluids, you have to give vasopressors, give blood cultures, but one of your cornerstone of managing patient with sepsis, septic shock is to look for the source control. And I can summarize it for you. For the source control, remember 4 Ds. D is for drainage. Second D is for debridement. Third D is for device removal. Fourth D is for definitive measures. D for drainage, if you have collection, abscess, you have to drain. Abdominal collection, empyema, so you have to drain, intervention radiology, and to drain. Debridement, like our patient, if you have soft tissue infection, neck FASH, soft tissue, you debride. Device removal, if you have cavity, remove the Follis catheter. If you have CLAPSI, remove the central line or HD catheter or big line or permicath. And definitive measures, if you have bowel ischemia, perforated viscous, you have to have mediastinitis, you have to have definitive measures. So this is the 4 Ds for source control. So remember, in very short summary, and we'll give you the bullet, that the diagnosis of soft tissue infection and neck FASH is primarily clinical one. You have to have a red flag when you have pain, which is out of proportion to your physical findings. Remember, there is no single clinical laboratory test or group of tests can adequately replace surgical inspection for diagnosis of neck FASH. If there is a high suspicion for neck FASH, with your clinical history and physical exam, do not calculate the Larenic score and go straight forward for operative debridement. The gold standard treatment of neck FASH is surgical debridement. Early outcome with the surgical intervention is the better or the earlier surgery is the better outcome. Surgical debridement should be early, within 6 to 12 hours, and should be complete from the start. As we mentioned, the rate surgical debridement beyond 2 hours time window associated, of course, of high mortality, high incidence of septic shock, multi-organ failure, and multiple further session of surgical debridements. Appropriate source control, remember, in general for septic patients is a key principle in the management of sepsis and septic shock. Source control should be achieved as soon as possible following the initial resuscitation from time 0 in the ER. Source control should not be delayed beyond 12 hours. This is your golden window. And remember well the core for these of source control: D for debridement, D for device removal, D for definitive measures, and D for drainage. These are the references, updated references applied from 2017, ending up by the latest Surviving Sepsis Campaign 2021. Dr. Hassan, طبعا because of the time allocated, I can.
عندنا وقت الحالة ثالثة. تفضل. حالة ثالثة.
Okay. So question number 3. I have patient who is 68-year-old male presented to the emergency department with hypotension and severe abdominal and back pain. He was found to have ruptured abdominal aortic aneurysm, AAA, and massive transfusion protocol was initiated from the start. Now his status post EVAR in the ICU. This EVAR done for the AAA. The nurse notifies you that his urine output continues to drop or to decline. The question is, which laboratory and or examination finding is the most suggestive of ACS? ACS here is not acute coronary syndrome, is abdominal compartment syndrome. So the choices are A, abdominal distension. السؤال بيقول what's the laboratory and or examination finding is most suggestive of abdominal compartment syndrome? A, abdominal distension with bladder pressure of 25 millimeter mercury with increasing oxygen requirement. B, abdominal distension with bladder pressure of 15 millimeter mercury and it changed oxygen requirement and it changed beacon inspiratory pressure and urine sodium of 80. C, mixed venous saturation 70%. D, cardiac ultrasound demonstrating obliteration of the LV cavity, and the repeat CBC demonstrated hemoglobin of 4 from the prior results. So please choose, and Dr. Najla, she will present the ball. So, Dr. Najla, can we present the response or responses? So, majority of our responses from your side, that 78% he chose A, which is the abdominal distension with bladder pressure 25 millimeter mercury, increasing oxygen requirement. This is a laboratory or clinical exam most suggestive of ACS. But 19% they chose B, that the abdominal pressure, abdominal distension with bladder pressure of 15 millimeter mercury with urine sodium and unchanged oxygen requirement, unchanged beacon inspiratory pressure, they chose B. C, they did not, 0, fortunately enough, and still 3% they choose cardiac ultrasound was obliterated LV and the drop of the hemoglobin in their answer. So thank you, Dr. Najla. So I am with the majority who choose A. Yes, in this scenario, the most correct answer is A, which is the abdominal distension with elevated intra-abdominal hypertension in form of blood pressure of 25 millimeter mercury, increasing with increasing oxygen requirement. So the rationale for this answer, that the abdominal compartment syndrome or ACS, it's a life-threatening, encompasses an increased intra-abdominal pressure in conjunction with the presence of, remember, end organ dysfunction. notably طبعا decrease renal perfusion and renal function, decrease pulmonary function, and reduce the preload. So this is the definition of abdominal compartment syndrome. So to differentiate this abdominal compartment syndrome from increased intra-abdominal or intra-abdominal hypertension. Typically, the urine sodium, for people who choose their own sodium and abdominal compartment syndrome is reduced in addition to decreased mixed venous saturation, which correspond to the reduce of cardiac output, but this is not the most suggestive. What about the cardiac ultrasound? Cardiac ultrasound should be or should correspond with the hypovolemia and setting of abdominal compartment syndrome, but a significant drop of hemoglobin to 4, it complicates a picture of active bleeding, not only abdominal compartment syndrome. So therefore, the most correct answer or the best answer is A, which is the abdominal pressure of 25 millimeter mercury, طبعا with clinical abdominal distension, but this is not only enough, only the abdominal pressure here. So just go for clinical teaching points. What about the intra-abdominal pressure? It's like iceberg. When you have X-ray, it's obvious that you have your patient is volume overloaded or he's congested, has pulmonary edema. So it's clinically obvious or radiologically obvious. But when you have intra-abdominal congestion, so this is the iceberg. You are not able to see it clinically or radiologically. So what's the definition of intra-abdominal pressure? Normal abdominal pressure is 0 to 5 millimeter mercury. Intra-abdominal pressure 5 to 7 millimeter mercury. They found it in most of the critically ill patients because most of them, they are ventilated, they are on PEEP, they are fighting the ventilator, they have constipation, ascites. So 0 to 5 millimeter mercury is the normal. Most of critically or ICU patients, they are ranging abdominal pressure between 5 to 7. The latest guidelines, they recommend that every ICU or every critical care unit, surgical unit, they should have a protocolized monitoring of intra-abdominal pressure in high-risk patients every 4 to 6 hours. So you have to be aware about what's abdominal pressure, what's the normal, what's your protocol in your unit, how you measure the abdominal pressure, and what's your intervention when you have elevated or intra-abdominal hypertension or abdominal compartment syndrome. The same as you are measuring urine output, the GCS, the blood pressure, the glucose check, it's the same. You have to have a protocol, especially in surgical trauma patients or even a medical ICU. And I will present later how the incidence in even medical ICU patient, not only surgical. However, what they found, 18 up to 82% globally of physicians, this was a survey, they indicate that they don't know, they don't measure the intra-abdominal. They miss or they are ignoring measuring the abdominal pressure. You can imagine from almost 20 up to 80% of critical care physicians, they indicated in such survey that they do not measure or they do not pay attention for measuring the intra-abdominal pressure. This graph depicts the difference or the landmark between the abdominal hypertension, abdominal compartment syndrome, and here once you go less than 5, so you are within the normal. 5 to 7, this is the majority of ICU patients, but once you reach above 12, now we are talking about abdominal hypertension. Now if moving up with end organ damage, you are talking about ACS or abdominal compartment syndrome. So for simple definitions, intra-abdominal hypertension, remember this very well because it's a very common in the MCQs and also in the OSCEs, because the examiner stresses on those numbers and definition. And this is what we call the golden numbers. So intra-abdominal hypertension is defined as sustained. This is very important. Sustained or repeated pathological elevation in abdominal pressure equal or above 12 millimeter mercury. While the abdominal compartment syndrome is defined again as sustained elevation of intra-abdominal pressure above 20 millimeter mercury with or without abdominal perfusion pressure less than 60 that associated with new organ dysfunction or failure. This is very important to differentiate between abdominal hypertension and the ACS. What are the grades of abdominal hypertension? We have 4 grades. Grade 1, abdominal pressure 12 to 15. Grade 2, 16 to 20. grade 3, 21 to 25. Grade 4 is more than 25, while the abdominal compartment syndrome is elevation more than 20 with new organ failure or dysfunction. We have primary or secondary according to the cause. We have definition of what's called recurrent or polycompartment. Polycompartment, it's the condition when you have two or more anatomical compartments that have elevated what's called compartmental pressure. And this is what we call, here we have abdominal compartment syndrome. Here, if there is an increase in the abdominal pressure, it consequently will lead to thoraco-abdominal compartment syndrome because it will increase intrathoracic pressure. And here, if there is an increase in intrathoracic pressure, it will increase the intracranial pressure. So now we have three compartments. We have abdominal, thoracic, and CNS compartment. So this is start from mono, ended by go to bi, then ended by polycompartment syndrome. And this is a picture that depicts how we start with the abdominal compartment syndrome, especially when you give a lot of fluids and you start fluid resuscitation in patient with third spacing, and you are keep giving fluids, patient is not producing output, and he start to have third spacing, increase in the intra-abdominal pressure, then the vena cava start to compress, reduce the preload, cardiac output, and the sequelae will start. And once the abdominal pressure will go above 12 to 15, so we will start the sequelae of decrease urine output, vena cava compression, decreasing the preload and cardiac output. Then 16 to 20, we will start to have worsening acidosis. And remember, if you have unexplained worsening acidosis with abdominal distension, so you have to think about abdominal compartment syndrome. If you have multi-organ dysfunction, patients start to be anuric, hemodynamic instability, increase in the peak pressures, difficult to ventilate, and you have brain edema. So now we have polycompartment syndrome. What about the risk factors for intra-abdominal hypertension and acute abdominal compartment syndrome? So many risk factors that we encounter in the ICU. Morbidly obese, BMI more than 35, patient with acute pancreatitis, patient with intra-abdominal sepsis or infection, patient with coagulopathy, shock state, hypothermia, massive transfusion protocol, patient with oliguria, volume overload. And they chose patients in medical ICU, not only surgical, not only trauma, and they have two risk factors of those: obese plus pancreatitis or sepsis or hemoperineum or intra-abdominal infection or retroperitoneal tumors. So they chose the prevalence, or they address the prevalence of increased intra-abdominal pressure or intra-abdominal hypertension in medical patients. They found with two risk factors that grade 1 and grade 2 between 12 to 15 or 16 to 20 were the majority, even up to 8 or 11. So 26% of them was 8 to 12 was only two risk factors. So you can imagine when you have more risk factors, you will have prevalence of intra-abdominal hypertension. And this is how to measure the abdominal pressure. It's very easy. The nurse can do it. It's a job of the nurse. You measure it through the Foley's catheter and the transducer. And the transducer should be dedicated transducer, not the transducer they use it for CVP measurement or for arterial line. It's dedicated for the Foley's catheter and measuring the abdominal pressure. And here is the zero level. The zero level should be at the mid-axillary line, not to use the philippostatic axis at the symphysis pubis, because it's underestimate the true pressure. And you have to learn or to teach the nurses how to use the abdominal pressure setup through the Foley's catheter. It's easy and can be repeated according to your protocol. Usually the recommendation is 4 to 6 hours. What about abdominal perfusion pressure? Is the pressure, we know about cerebral perfusion pressure. We know about MAP, main arterial pressure. There is a similar one called abdominal perfusion pressure, is the pressure gradient between the MAP and the abdominal pressure. So you have to know your MAP and you have to know your abdominal pressure. The abdominal pressure, it drives the perfusion of all intra-abdominal organs, including kidneys, spleen, and the bowel. It's best to maintain the APP more than 60. If the APP, which is the abdominal perfusion pressure, اللي هو الماب minus APAP less than 60, this is a red flag, please, and it should predict the need for urgent surgical decompression. The target map might be better to interpret as 60 plus IPAP, and this is very important. Hemodynamic interventions, it should be tailored for each particular patient. If patient is hypertensive from the start, you should target higher map. Considerably, the early vasopressor to target higher map, because of adding more fluids, it will aggravate the abdominal tissue edema and more increase in the abdominal pressure and high risk of abdominal compartment syndrome. So this is the equation for APP in millimeter mercury, MAP minus intra-abdominal pressure, and should maintain above 60. And the target MAP, as we mentioned, you have to incorporate abdominal pressure because your ICU patients have their baseline of 5 to 7. Just to address the volume overload in critically ill patients and the risk from day one. So Paul Mark in 2017, he published a study of relating the volume overload in septic patient during the first day of hospital admission and resuscitation. Patient who received more than 5 liters of fluid correlated with increased mortality because of increase of abdominal pressure and bowel edema. And these are the guideline published in 2013. This was the abdominal compartment syndrome, compartment society. So you can imagine that how this syndrome is important. There is a specific society that published this guideline called Abdominal Compartment Society. I will go quickly because through this management algorithm is very important. Once you have abdominal pressure equal or more than 12, so you have to look for intra-abdominal content to address how quickly in 4 steps can I go intra-luminal content evacuation to evacuate the intra-abdominal space occupying lesion, especially if you have bedside ultrasound and ascites, to improve the abdominal wall compliance if your patient has adequate sedation and analgesia, not fighting the ventilator, and to drain ascites or to paralyze the patient if the patient not well sedated, not well having a proper analgesia. To optimize the fluid administration when you have a fluid responsive assessment, and to optimize the systemic peritoneal perfusion through the hemodynamic monitoring and to guide your resuscitation. So this is how can we address the abdominal compartment syndrome. So failure to consider, in summary, failure to consider the abdominal compartment syndrome is a common phenomenon in all types of patients, not only surgical critically ill patients. And lower index of suspicion, you should address it and manage adequately according to your clinical and abdominal pressure measurement. Over-interpretation of the blood pressure obtained in patients who are not supine and breathing passively. You have to sedate your patient, so sometimes you want to paralyze him because you don't need to overestimate or to underestimate the abdominal pressure and to measure it adequately. Abdominal compartment syndrome, it compressed the inferior vena cava, making it looks empty. This is from the pathophysiology, and this may lead to wrong decision regarding the fluid administration. So be careful when you have abdominal compartment syndrome and the inferior vena cava by echo or by ultrasound looks empty, but this is not the truth. There is numerous non-operative therapies for abdominal hypertension and abdominal compartment syndrome, like restrictive fluid administration, diuresis, dialysis, before you go for surgical intervention. If the abdominal pressure above 20 with new organ failure or dysfunction, this present an abdominal compartment syndrome. And if you apply the medical management in the form of restrictive fluid administration, diuresis or dialysis or tapping, and still refractory, so you consider early surgical intervention for decompression. These are the references with the guidelines, and there is a clinical guide management published in 2020 in the Critical Care Journal regarding a very nice one for the clinician guide for managing the intra-abdominal hypertension and abdominal compartment syndrome in ICU patients. Thank you, Dr. Hassan. Thank you, Dr. Najla. I will